So, good morning, good afternoon, and good evening to all of you around the world joining us on our very first webinar for Surgery International called The Future of Surgical Robotics. For the next hour, we'll take on a journey with an esteemed panel to discuss what's happening currently in robotic surgery and what the future might hold, which is obviously extremely exciting for all those involved in our profession. First of all, a little bit about Surgery International. We launched this platform a year ago to build a community of surgeons globally, to understand what's going on in every corner of the globe, to share the news stories and the wonderful achievements of surgeons around the world, and also the issues that are raised both from a surgical perspective and politically. We cover all areas, and we ensure that we create a community of surgeons to drive our profession together, to increase our workforce, to improve our workforce, to inspire the next generation of surgeons is our mantra. So Surgery International was launched over a 2-year period a year ago. We now have registrations and subscribers from 138 countries. So really pleased at our mission of connecting surgeons across the world to improve the outcomes. In our background today, we have our commercial director, Andrew Buchanan, who's managing the webinar for us. Julia Price is our marketing director, who set up the whole program for us. And Tim, who's part of the panel, is our editor at large, bringing that news together for us. It's a free subscription, so please do join us at Surgery.International.com, and we're pleased to welcome you to join our community. We do podcasts, webinars on a monthly basis, and lots of other events that you might be excited to attend through the website. So do please subscribe when you can. We have to thank 2 sponsors today, Horoscoptic, who are a global leader in producing surgical loops, and they're the gold standard in surgical operating tools. The other, of course, our big partner, it's the Royal College of Surgeons of Edinburgh, and they've been supportive since day one. We've launched our program to ensure they connect us to their global community to help support their ambitions, and also a way of managing the news stories that we share across the world. So thank you for both of them for helping us launch our webinar series. The webinar series will be on a monthly basis. Today, of course, about robotics. Next month, we'll be covering sustainability of surgery, looking at how we can get to net zero by 2050. Then we'll talk about leadership, and also talk about the digital surgery and the digitization of the operating room. So please do join us in future webinars. We'll be once a month advertised on our web platform. Now, on to our webinar. So surgical robotics is so exciting. Over the last decade, we've seen such huge changes. If we go back to about 1992, when the first robot was used to perform a surgical operation, it was called RoboDoc. Sounds like a Hollywood film. It is a robotic operation for orthopedic surgery. Prior to that, the first procedure of such was 1985, using the Puma 200 to do a brain biopsy. But of course, since then, we've seen the explosion of surgical robots, the interest, the passion, and the number of cases just accelerated. So how many cases are being done? Well, globally, over 10 million operations have been performed over the last 20 years or so, and that's increasing exponentially. There are about 10,000 surgical robots on the market, obviously starting with Intuitive Surgical, launching the Da Vinci series, and really being the pioneer for all of us to understand how robots have come into being and the use cases and the validation through clinical research and trials. We know that Da Vinci have now launched the new SP, the single port robot, which we're excited to see what can be achieved with that. And I think that's a real major step forward in surgical robotics. They've also asked FDA approval for Da Vinci 5. Who knows what that's going to bring? I'm really excited to see what they're going to be producing over the next 12 to 18 months to improve on the Da Vinci Xi. But now there are lots of others in the market, of course. Our own UK company, Cambridge Medical Robotics, has been amazing over the last few years with its Versia system, a portable modular system that's really challenging the traditional players in the market. It's done very well in terms of getting global capture and very successful in what they've achieved. But of course, there's others like Medtronic with the Hugo system now being launched. And also we've seen the orthopedic robots around, including the Mimi, the micro-medical robotics for microsurgery and plastic surgery, for example, really pushing the boundaries of what's achievable in robots. And we're also seeing the world of orthopedics in robotics with the Mako system and others who are now also saying, how do we also get involved in this world of robotics? So there's a plethora of robots out there, each getting better and better, more sophisticated, more data-driven. And so it's exciting to see what that next 5-10 years is going to look like. And the latest one that we've come across is the SS Mantra. India has its first robot created within India by Indian engineers and pushing out. And they've done their first 500 operations in December of 23. So democratization of surgery, globalization, and impact on a global level. Thank you for joining our webinar. We now are up to 1,207 registrations for this webinar, one of the biggest I've ever come across. I've run webinars over the last 10 years, and this is a huge number, and from 82 countries. So thank you for joining us from wherever you are in the world. We'll spend the next hour. What we're going to do is get an introduction from our esteemed panel, then we'll go straight into the discussion. I'll pose some questions to our audience and to our panel, of course. But I want you to get involved. There's a chat button, of course, on Zoom. Please use the chat to ask our panel questions or comments. Please have a conversation. It's all about being interactive. And we'll post some questions at the end of the webinar to our panel guests. So first of all, I'll get them to introduce themselves for a minute each, starting with Tim Lane.
Hello, everybody. My name is Tim Lane. I'm a consultant neurologist at the Lister Hospital in Hertfordshire. For those of you not from the UK, it's the bit just above London. I've been there for nearly 20 years. It's a large district general hospital, which is the tertiary referral centre for urological cancers for the county. Our robotic service was established about 15 years ago. We were the first unit in the UK to be accredited with fellowship training by the Royal College of Surgeons. I'm the former chair of the Court of Examiners for the Royal College of Surgeons. So I apologise if at any stage you've had to retake your MRCS. And I'm also was a former editor of the Annals of the Royal College of Surgeons. So I also apologise if I ever rejected any of your papers.
I don't think you rejected any of mine, but don't worry, Tim, that's not a question of the day. Going from right to left here, Bhavan Rai.
Hello there, everybody. My name is Bhavan Rai. I'm a consultant urological surgeon and a robotic surgeon. I was actually trained by Tim. I now work in the Freeman Hospital in Newcastle. We're the northern part of England. We support the Newcastle United Football Club. I deal with patients who have prostate cancers and upper tract urothelial cancers. I was taught by Tim, but I now lead the robotic training program in the Northeast. In addition to this, I'm also the course director of the annual cadaveric robotic program in Newcastle, which is one of two in the United Kingdom. And I really look forward to this meeting. Thank you.
Thank you, Bhavan. Peter.
Well, good evening. My name is Peter Vaughan. I'm a consultant colorectal and robotic surgeon from Edinburgh. So I work in a large colorectal unit, one of the largest in Europe, and we're a tertiary university hospital. I undertook a intuitive funded robotic fellowship in Sunderland 2 years ago, which preceded my consultant post. I've got a great interest in training. I was the Duke's president with the UK wide arm for coloproctology, and I currently sit on the Edinburgh College Robotic Task Force. So really strong emphasis in training the next generation of robotic surgeons. Thanks for having me.
Thank you, Peter. Paul.
Yeah, hi, Paul Gibbons. So I'm from the industrial side here. So at the moment, I'm MD for Corin in the UK. It's a UK-based orthopedic company that's aiming to combine technology with proven orthopedic implants. My background's almost 30 years of orthopedics in different areas, originally from the development side, the bioengineering side, through international marketing, and then eventually into general management. So looking forward to having a chat tonight and talking about some of the industrial side of things, which is slightly different sometimes to the surgeon and the clinical side. So thanks very much.
Thank you, Paul. Tom.
Hi, everyone. My name is Tom Schrader, and I'm currently representing the secondary market for surgical robotic systems. I've got over 15 years experience selling and supporting pre-owned medical equipment, specifically in the diagnostic imaging and now in the surgical robotics space. I'm co-founder and president of Medco Blue, which is a global supplier of pre-owned and refurbished diagnostic medical imaging systems. Founded in 2015 here in Toledo, Ohio, in the United States. My experience there extends to buying, selling, installing, deinstalling, servicing, shipping imaging equipment around the world. And in 2019, after seeing the explosion of investment into the surgical robotics industry, I founded and am president of a second company called R2 Surgical, where my team and I supply on a global scale pre-owned surgical robots, instruments, endoscopes, disposables, and also offer some level of equipment support and ancillary training. Our goal is affordability, sustainability, and what I aim to bring to this conversation is my experience and knowledge of surgical robots in the secondhand industry, which, while in its infancy, it's growing rapidly, but it's here now and available to hospitals and surgeries around the world. In short, I hope to answer the questions, what are the different ways to make surgical robotics more affordable, accessible, sustainable, and what might the future of the secondary market look like? Thank you.
Thank you, Tom. That's a really important topic that we'll come on to in due course. First of all, I've making a bit of an apology from Surgery.International. We're not well represented on our panel here. It's all men, of course, and we do recognize that. We did reach out to a number of female surgeons who couldn't make it tonight, so apologies. But of course, we can and should do better. With our next webinars, it'll be more representative. So apologies from our side from that perspective. However, we need to move on. First of all, I'll put into context. Tim, to you. You're a urological surgeon and really one of the first surgeons really to kind of embrace robotic surgery for the last 15, 20 years. Where are we in the current scope of robotic surgery? Can you just give a quick overview? Thanks.
I think if you were to the current landscape could quite simply be characterized by one in which robotic surgery and robotic systems are becoming increasingly embraced by healthcare organizations. It's a landscape in which there are an expanding number of applications for robotic surgery, and with more specialties becoming involved and using the robot for even greater number of surgical interventions. It's a landscape which technology associated with robotic platforms are undergoing rapid advances. Thankfully, it's a much more crowded landscape nowadays. One which was once dominated by a single company is now populated by a large number of other players. You've mentioned some of them: Medtronic and their Hugo RAS system, CMR, Stryker, joint replacement robots, sensors. There's a whole list of these things. And this is providing some real diversity now amongst the main protagonists. And that's the thing that's beginning to change and push back boundaries in the robotic field.
Thank you, Tim. Now, for surgeons who are starting out, often you get appointed, there's training, which we'll come to in a moment, but it's setting up a service, which is actually quite difficult. There are a lot of barriers to that. So, Bhavan, at Freeman Hospital, now that you've been there for a while, if someone will set up a new robotic service, what are the barriers they might encounter? And can you give advice on how you overcame some of those barriers in your training and also, for example, in your clinical practice?
So there are a couple of elements when we introduce a robotic service. You have to find out from your own service what its needs are. And that depends on the size of your hospital, the specialties you have. So you could either run a single specialty. For example, you could have a purely robotic urology service, or you could have a multi-specialty service. In larger hospitals, you can run single specialty services because the capital costs are covered by that. But if you have smaller hospitals, it may be an idea to collaborate with other specialties. That way you save on some of the capital costs because a lot more units are benefited from it and you have your numbers. In addition to this, we have to understand that running a robotic service is not a single individual. There's multiple groups of people that are involved in it. So you need your nursing team that's well trained. You need assistants who are well trained, and having specialist scrub side nurses may be a model that people may want to consider. And thirdly, I'd also strongly recommend having a robotic coordinator who brings all of these individual aspects of a robotic service together. I think the challenges that we may have faced in the past may not be contemporary challenges. I think it's becoming less difficult to convince organizations that robotic surgery is the current and the future. But I think now it's about integrating these services more efficiently. And these are some of the suggestions that I would have for people who are planning to develop these services.
Thanks for that. I'll come back to just one question about CapEx, capital expenditure. They are not cheap. We'll come to that again later on when we speak to Tom about this, right? So how do you write a business case? How do you justify having a robot in a hospital when there's so many competing pressures, particularly in the NHS and other hospital systems, where cost is always going to be prohibitive?
This has been a question that's, we've argued about this for a number of years, and it has been one of the challenges within robotic surgery. But I'd like to look at it slightly differently. Now, when we talk about democratization of surgical approaches, we often don't talk about democratization of surgery as an option that is offered to patients. What you will have with robotic surgery is a wider proportion of your surgical cohort that are able to offer surgery as an option and offer it to patients. As a consequence, what you will have is a wider group of patients who benefit from it. You have a larger proportion of surgeons who are able to offer a technique. So geographically, you benefit. In addition to this, if you look at costs in the long run, the complication rates, the readmission rates tend to decrease with time with robotic surgery. So for in a public funded system, for example, like the NHS, we do notice that robotic surgery, particularly in procedures such as radical prostatectomy or partial nephrectomies, may eventually become cost effective. But it requires for us to do a large volume of procedures to achieve that balance.
And urology have done very well from looking at large volumes over the last 20 years or so. But it's the government's politicians that might not have that long-term approach in looking at outcomes and sustainability. We'll come back to that in a moment, because I think that's a really interesting conversation to have. One of the key elements is training. I remember I'm a colorectal surgeon by background, of course, and I went through the whole open to laparoscopic surgery, which was a big change about 20 years ago or so. Now, of course, there's a new direction of robotic surgery. Peter, you have a big role at the Royal College of Surgeons of Edinburgh around training, part of the committee. What are your thoughts around training? How do we train consultant surgeons who want to push the boundary? And then what do we do about the trains coming through around how they adopt these new methods?
Yeah, that's a tricky question, and just like balancing the cost spreadsheet, there's a balance in terms of training and the cost of training to the individual people within a training rotation and within a hospital. So if you're training your consultants to do robotic operation X, well, the trainees, the registrars or the surgical house officers, as we might call them, they have lost that training opportunity. So it's about actually making sure everyone has an opportunity to train in a different bit of the operation. Now, the one thing that robotics brings to us that we haven't had before is real high fidelity training simulators. Obviously, we may all have stacked polo mints in the laparoscopic trainers over the last years, which really did not prepare us to do a laparoscopic operation. But some of the high fidelity robotic simulators really do prepare you for every step of an operation, as do some of the other sort of cadaveric and other models that are available. I think the critical thing really is making sure that training is balanced, so there are opportunities for all seniority of surgeons. The critical question thereafter is whether or not training should be platform agnostic. So do we train someone to be an intuitive surgeon or a Medtronic robotic surgeon or a CMR surgeon, or do we give people the skills to be a robotic surgeon in general? And I don't think anyone knows the answer to that yet. And the curriculum developers, be that the GMC or the higher surgical training bodies in the UK or elsewhere, that's the question they need to answer. The thing is, trainees desperately want to do robotics. They think it's, the next big thing, and it probably will be. What I tell every trainee is that you need to learn to do the operation first, and there's a little bit of you need to walk before you can run. So don't get too hung up about needing to do a robotic anterior resection. Learn where the ureters are, learn to do an anterior resection, and then actually it's a pretty quick step up towards becoming robotically competent.
And so, I mean, well, I remember going through open surgery, laparoscopic surgery and LAPCO and the way it was arranged, for example. Have we learned anything from that whole process of going to open to laparoscopic and now going to laparoscopic robotic? If so, what of those learnings have been managed better on this occasion in your mind, Peter?
So I'm afraid I'm going to show my age here, which is that actually I didn't go through LAPCO. I came through a training scheme that was a laparoscopic training scheme primarily. But I suppose the lessons maybe are don't lose sight of your fallback option. So for colorectal, the fallback option is either laparoscopic or probably just an open operation. And don't allow yourself or your specialty to become de-skilled, because there will always be the need to do an open pelvic operation, be that in an emergency setting or in the context of the very rare conversion. So maybe I think one of my biggest suggestions is don't allow sort of skills to become in the sort of ether of history, because those skills might be critical to you in the middle of the night when you're all on your own and there's no chance that the robot's going to get you out of trouble.
That's true. Although the robot may actually do the operation, who knows in the future? But that's a discussion another time. Coming to you, Paul. Now you've had a lot of experience, of course, in the industry. And one thing I like about the current modern world of medicine was industry and clinical practice now are really being merged. Before they were quite separate entities, but COVID has shown us that we need industry partners, we need to work together to build that future together. As a bioengineer and your background in business, tell us about what's going on from your side and the world of orthopedics, which you mentioned earlier to us prior to the phone call.
So I think we've always been quite closely aligned with stakeholders and surgeons and developing new products, and there was always an ongoing chain of products being developed. I think what we start to see though is the results, the clinical improvements of those big investments in implant development and instrument development starting to decrease. So you're putting a huge amount of money in and getting less and less out of it at the end. The regulatory portfolio is really much harder, much more expensive, much more time to get through those. So people are now starting to say, well, hey, it's maybe not just the implant now, it's other things around it. What can we gain? And who do we need to partner with to get that information to take the next step? And that's working closely with surgeons in some cases, but also looking at working with different people. And you're starting to say, okay, where do I get the people within the company or outside of the company to give me that technology data? So programming data, data analysis people are becoming now as important as a classic metal bending bioengineer as I came into it. And that's just starting to happen. I think we're just at the front of that coming through and saying, all right, this partnership moves us from kind of the orthopedic robotics we see at the moment, which is still target focused and making sure we're on target to saying what is the next target that we're looking for, what's the intelligent target that we're going to go for in the future, and take that data set to take us to there. So it's really interesting, and you've got to be open to that and open to just completely different ways of doing it.
Thanks for that. So you're seeing now incremental changes in instrumentation, but perhaps gross changes in kind of robotics as I can see that. And that makes sense. And you're right about the data. We'll come to data in a moment, because that's going to be the key player in looking at the future of predictive surgery or personalized surgery or improving outcomes based on data acquisition. And we'll discuss that in a moment. Coming to Tom, we mentioned earlier the cost price of a robot, which is quite prohibitive for a lot of countries around the world. The robot companies always tell us we're here to democratize surgery. Great ambition. I love that idea. And that's where I come from as well, to make global health more attractive to people. However, the cost is quite expensive. I think a Da Vinci might cost $2.5–3 million, for example, US. The price is coming down. Ongoing costs of maintenance. The instrumentation is not cheap either, and some of those have a life expectancy of 10 or 20 operations, for example, limiting factor. And so it's not cheap. What you've done now is take that whole concept, actually, can I make it cheap and affordable to the second-hand market or etc. I'd love to get your thoughts on what you're thinking around the work that you do and what's been the impact of your work globally.
Well, yeah, we get to see that firsthand. So the reason we even kind of came around in the surgical robotics space is because healthcare institutions, hospitals, smaller surgery centers around the globe, we're currently representing customers in all continents except for Antarctica, that basically came to us and said, hey, you know, we can't afford new. We don't have the patient throughput to qualify as a customer, or, you know, we just want to save, you know, and then we have other customers, even in the veterinary space, that want to kind of extend and do some research and see if they can extend that surgical application to robotics to animals, in this case, dogs. But yeah, so what we've been able to do, and it's primarily in the Da Vinci space. So we started off specializing in the Da Vinci robots, primarily the S and the SI model. And what we've been able to do is partner with, you know, some former manufacturer engineers, specialists, some technicians, people who know the robot inside and out, who were kind of on the ground floor helping develop a lot of the processes and just know how to make, you know how to support it and make it, you know, sustain their program. So we've been able to connect these hospitals with some robots, you know, where we offer more than trade-in value. We connect them with the robot, and then through some of our partnerships, we've been able to help them, you know, keep the equipment functioning. You know, through our own endeavors, we've been able to, you know, keep a stock of, you know, instruments and supply them with that, help them with, you know, a level of proctoring, sterilization training, staff nursing training. And it's been very successful. It's primarily not in the United States. Well, we do have customers here in the United States. It's primarily in some of the more developing countries. But it's been very successful. We've had wonderful feedback. We work very closely with these hospitals, and they've been very appreciative. So, and then you know, I think you know, the future is going to be some of the non-Da Vinci robots, but currently, that's, you know, where we can offer the most.
It's amazing. And can you tell us about some of the countries or hospitals you worked with, and how remote are they, and where are they in the world, for example? It'd be good to get an idea of where you work.
Yeah, sure. So some of the countries that we exist in would be, just for example, you know, Venezuela or Poland and Turkey. We're even in Iraq, and you know, a handful of others. You know, and what we've been able to do is, you know, some of the countries, you know, we don't have the ability to kind of fly there and be there, you know, on a moment's notice. So what we've actually done is really equip the hospital and train the hospital as best as possible, including their, you know, maybe their biomed team, so that they can, you know, be kind of first responders and be the first ones to try to keep their equipment running while we provide support remotely from either the United States or from one of the other countries our engineers are in. So, and that's actually been very successful. And we really focus on, you know, helping them keep their equipment, you know, well maintained, operating at a very high level, so that it doesn't break down. So that's a focus.
What's the cost of a Da Vinci Xi in the second-hand market, or the resale market, we like to call it? Do we have an idea of what you expect now?
Yeah, and honestly, it's about the same as you could expect for any of the non-Da Vinci robots, and that's about between 50 to 70% off, which is sizable, and it's something that we've been able to, we've been able to make that happen. We're able to offer a trade-in value that's much higher, but still, and sell it, make some sort of a profit, but it's still 50 to 70% lower than what they would have to spend if they were going to buy it brand new. And, for the Da Vinci robots, we can do that plus offer, some support, and help them with the instrumentation. But, and as far as the non-Da Vinci robots, when we're talking about the Stryker Mako, or the Globus Medical Excelsius robot, we've been able to connect those pre-owned systems with hospitals and actually work with them and help them navigate the conversation with the manufacturer to make sure the manufacturer will provide support. So that's
always
success too.
It's one of the criticism, isn't it, about support ongoing on existing systems. So thanks for that. And it's great work that you're doing to bring those robots to markets that might not have been able to get them otherwise. Tim, I'm going to ask you a little controversial question, right? Robots are kind of here to stay, we believe, but the outcome measurements aren't any better than other forms of surgery, which has always been, I think prostate may be better. Colorectal, for example, and other looking randomized controlled trials, you can't show real benefit as such, apart from visualization, maybe, and access to parts of the pelvis. So here's my question. Is it the right thing that we're doing, bringing these robots into clinical practice?
We've always been really bad at doing these things. Most of the robotic stampede came before any randomized trial. And the honest answer is there were units who were doing laparoscopic procedures much more cost effectively with just as good outcomes long before robots came and are continuing to do that even now. So, in terms of cost effectiveness and outcomes, some units have had real difficulties in trying to switch to robotic surgery because management will tell them, well, actually, you're already getting fantastic outcomes. You're doing it quite cheaply. And you're right. And there isn't a huge store of studies which have said, well, this is a better outcome. But I don't think it's just about that. It's happened anyway. And this is always the case. It's happened. I don't think you can close the stable doors. It's here. And there are some advantages, not only in terms of shorter stays, less pain, less blood loss. I'm not sure there's any study that shows a better outcome in terms of oncological outcomes of robotic surgery over open surgery. But, most of those are pretty similar. But it is a much easier transition from open surgery to robotic surgery. Now, most of us went through robotic, laparoscopic, and then on to robotic surgery. And, it's a difficult transition from open to laparoscopy. It's a much easier one from open to robotic surgery. So I think you're right. There isn't that wealth of information to say this is better on clinical grounds. But we are where we are today, and there are huge advantages, and there are better advantages to come. It's a rapidly changing field, and I think over time those improvements will become much more evident.
Thank you, and I agree with you. The horse is already bolted. We are where we are, and I think it's really exciting bringing more of this in. And one of the things that actually I think robots have advantage going forward, it's the world of data. You've got lots of measurements coming in, data coming in, capturing every movement of the articulated instrument or the robot, for example. And so when we look at the future technologies, what I described in an article I wrote recently is a concept of digital surgery and the pillars that underpin the new concept with immersive technologies, AI-driven, data-driven pathways and outcomes, including teleproctoring, telementoring. We've already seen 3 or 4 years ago the world's first 5G-enabled robotic operation happening in Eastern China. Now we're seeing it regularly, the people in China performing operations like hysterectomy remotely using robots. We've seen that now becoming a thing. So, Bhavan, I had a lovely chat with you the other day about the word AI. Look, if we didn't mention AI today in this webinar, we wouldn't be doing ourselves justice. If we didn't mention ChatGPT at least once, then I'm afraid this webinar becomes non-viable. So, you're doing interesting research with India around AI, data, and perhaps looking at how that affects outcome. Can you tell us more about your thoughts around that, Bhavan?
See, one of the benefits of robotic surgery is that we're able to garner a lot of data. The platform allows us to do that. Now, analyzing this data with more conventional models may not be that straightforward. And that's why when you combine robotic surgery and artificial intelligence, we have the ability to analyze some of this very complex data in very sophisticated manners. And I'll give you some examples of this. Now, Peter spoke about training in surgery. With all of this information that we have, we're able to add a scientific element to how we offer training. So, for example, in robotic surgery, we can study hand movements. We can study automated performance metrics. We can then bring it down to precise hand movements that are the most likely to offer the best outcomes. So this is where artificial intelligence comes into play. In addition to training, we talk about predictive modeling, we talk about personalized medicine. Again, because we have a lot of this data, we can combine this with non-surgical data. We can combine this with individuals' comorbidities, and then eventually precisely predict with these models whether an individual will benefit from a certain approach or not. We also have to look at autonomous surgery. There are various forms of autonomy within surgery. Now, we've got self-driven cars, for example. Mercedes has produced self-driven cars. There have been some semi-hybrid autonomous models. There are biopsy techniques. There are bowel anastomosis. There are benefits to this. Particularly, again, when we talk about democratization, what are we really trying to achieve? We're trying to achieve offering surgical techniques to areas where perhaps surgeons may not want to go. They're remote. We want standardization of treatment. So when all of these technologies have these benefits that we can achieve with both artificial intelligence in various forms, be it predictive modeling, be it training, be it standardization of techniques, and accessibility of techniques as well.
That's great. And the work you're doing in India, can you say a bit about that, the research project that you were mentioned to me briefly before the webinar?
See, a lot of the work that we've done is integrating a lot of the data that we've had. So we've got artificial intelligence engineers, and because they have the ability to analyze this data, we're able to produce predictive models for various cancers. For example, upper tract cancers is one of them. In addition to this, in Britain, Newcastle was involved with the Mastery trial, which include various surgical specialties, where we've absorbed a lot of the data from surgeries, and we're developing surgical curriculums by looking at what hand gestures that an expert surgeon performs, compare it against trainees, and eventually we will bring it down to very precise hand gestures, which we will subsequently incorporate into surgical curriculums and teach trainees exactly how they must be delivered.
Yeah, I think that's great, because what we'll be able to do is assess a performance. At the moment, if you look at surgical performance, it's very analog. It's around judgment, performance. No one's really assessing your quality of outcome or your operation intraoperative. We have the OR black box now by Theodore Gruncher from Stanford, looking at all the video feeds that are coming through and seeing if they can look at risks, analyze mistakes, for example, using video technology. I think one of the things going forward is about computer-aided surgery. So, Peter, the future surgeon, future robotic surgeon, right? One of the things we don't have is information at hand. It's based on our clinical judgment and years of experience, which is where, of course, you come in with your years and years of experience through surgery. Computer navigation, surgical navigation is becoming now a thing. People are now looking at lap colis and saying we can actually predict where the CBD is, for example, and avoid structures. We've seen the kind of the dyes now used in colorectal surgery to define lymph nodes and perhaps where the operative field should be. What are your thoughts around computer-aided navigation and visual, I guess, computing, or around what might be achievable in the next few years and what might help you?
Well, I think if you think about your car, you're driving your car, and if you're about to hit a wall, a big alarm goes off, and this doesn't exist for surgery. And you think, well, surely our technology and the cost of our systems are so much more than a simple sort of radar system in the car. So what might we be able to bring in? And really the opportunities are endless. But we've mentioned already a few. Major vessels. We can run some sort of fluorescence molecule into a vessel or some sort of tracer, which means if we're going near that vessel with our robotic instrument, either there's an alarm or there's some sort of brake put on, like the driving instructor pushing the brake, which means that you're not about to cut the internal iliac artery or the vein, to make sure that you don't make those mistakes. And then the other thing is, really, if you think about breast surgery, the evolution of breast surgery, they've gone from doing massive mastectomies down to really finely controlled, precise lumpectomies. And in the progression of, for example, colorectal surgery, we're really beginning to think and tease out, options to organ preservation. And this is allied to increases or improvement in surgical oncology and all the different chemotherapy and the immunotherapy that's available. So, can we imagine a system where the robotic system, the augmented reality, all the various tracers can tell us exactly where that cancer is? We take a very small bit of tissue around that cancer, we let immunotherapy or chemotherapy do the rest. So I think we can see robotics as it's effectively precision medicine or precision surgery. How can we move from doing a big mutilating traumatic operation in the analog open sense, big cut, rip it out, to actually a really nice, precise, minimally invasive, minimally traumatic operation with all of these adjuncts available to us, be they televised onto our screen as some sort of augmented reality, or using the tracers or the sort of the fluorescence markers that are available. And then the one thing we haven't touched on, which is a disadvantage of robotic surgery, is the lack of haptic feedback. So, are the next generation systems going to actually allow us to know what's soft and what's hard because you just want to prod it with your finger. So hopefully that will be coming, and that will be combined with all of these sort of visual cues and augmented cues that I think will really help us to be really precise surgeons.
Yeah, I think so. Precision surgery is kind of where we're heading towards. And I think that's a good thing overall. Targeted, specific organ preservation, and that may be part of the whole data analysis going forward. Just to the audience very quickly, in about a few minutes, we'll be going to a Q&A. So please do use the chat in the Zoom bottom tray to just put your questions up. I have some questions ready, and we'll go to the panel in a few minutes. And now back to Paul. Engineering. Obviously, we've done amazing things with robots over the last 20 years. For you, what does the future look like in terms of what engineering or new ideas do you see on the horizon that we can look forward to from industry and our partners in medtech?
So taking it very orthopedically, I think we're going to see this move from static 2D pre-planning without too much sort of patient data into there to full 3D dynamic. How do patients move? Each patient kind of moves differently. So then you get the data analysis bit that gives you patient phenotypes. And then you're starting to see people now clumping the data together. So you can say this patient needs this, which I think we've been hearing from some of the other guys. But the key bit then is the sensors that you build around your robotics, or just if it's not robotics, it's assistive technology. It's some sort of piece that gets you to the position you need to be, but builds in that soft tissue data to say, okay, yes, we've looked at putting something in quite accurately, but now we need to build around it. That patient needs this type of movement. We can do that if we're also sensing the intraoperative data that says this joint moves this way, and therefore build that all together in the plan intraoperatively to say this is the best outcome for the patient. Gather the post-op data, run that back into the pre-op and the intra-op, and keep proving it that way as you're going forward. And I think that's the jump that we'll see quite soon, compared to hitting a target and seeing what the robot effectiveness is from hitting a target.
Great. That's really exciting. I'm going to go to the questions now, and just see what we have on the Q&A. So there's quite a few questions there. Rami, good to hear from you, Rami. I was with your colleague only a few days ago having a coffee in London, who are actually introducing a fantastic new robot for urology. And Tim, you will love it, as will Bhavan. It's called the Andromeda, and it's going to be replacing cystoscopy in the future and prostate surgery using completely autonomous robot. Watch out for it. It's coming out soon. Rami, share that with me. But Rami's question is ergonomics. One thing we've got to think about is patient of the surgeon's position. You know, I don't know, after 30 years of clinical practice, I've certainly had backache on and off for many years and struggled with major cancer resections. But for robotic surgery, being on a console, it's going to be better long term, right? In terms of physical attributes, etc. Tim, what are you thinking? Is your back hurting?
Not anymore, although actually everything aches nowadays, if I'm honest. But I don't think that's got anything to do with surgery. No, it's fine. I mean, it's you can adjust consoles, the height of your pedals, your arms, and it's very comfortable. And I think it makes what is sometimes a longish operation very comfortable. So I think ergonomics is important. But it's part of the whole the bigger picture with surgeon burnout and things like that. It's something that Beth Fratch, who was one of our features in Surgery.International, talked about health and well-being of surgery, and ergonomics was a large part of that. And so the robotic platforms we're using at the moment are specifically designed, perhaps for the first time, with surgeons in mind. I think that's a positive point.
I'll just run through as many as I possibly can. Loads of questions to go through. Peter, you want to say something? Go for it.
Yeah, I was speaking to my financial advisor today, who advised me that probably by the time I get to retirement, the state pension age will be above 70. So I think ergonomics and longevity of surgeons is critical. We are an expensive and finite resource, and if we can do 5 anterior sections a week robotically, as opposed to maybe 2 laparoscopically, that's going to have massive benefits for the societies and the patients that we serve.
Yeah, thank you. And that's a really interesting point, of course. I was in a conference in Dubai about longevity, how we maintain our health for a lot longer. And if you look at the drivers in the Middle East, it's about longevity, improving lifespan and health span. And actually, that's very relevant to a surgical community. We might be operating till 70, 75, for example, in the future with good health. So that really makes a lot of sense to me. A question from Hussein Lubad from Palestine. I'm sorry the problems you're having in Palestine. I've been in Gaza many times working, trying to build capacity. And our heart goes out, of course, all the people in the Middle East who are suffering currently. The questions are, this is for you, Tom, I think. What's the future scope of surgical robots in low middle income countries, which I think you covered a little bit? And also, are there any roles for surgical robots in trauma surgery in conflict zones? So do you want to take that question around low middle income countries and conflict zones?
I mean, the trauma side of things is I think where robotics.
That's for Tom.
Oh, sorry, beg your pardon.
Oh, it's okay. It's okay. I just thought it's relevant for him. Thank you.
So as far as Middle East and conflict zones, we are very aware and actually experienced in that, and actually most of the burden and responsibility is on the hospital itself. We're able to provide robots kind of anywhere. We can ship it anywhere, but really the burden is on the hospital. So one of the countries I didn't mention is actually Ukraine. We support a couple different hospitals there, and obviously they are looking down they've got Russia at their back door, and they're going through that daily. This is not something that, while it does affect us, we really just try to support them the best way we can. But as it relates to any country experiencing any, civil unrest or political issues, it's up to the hospital to determine if that's, if robotic surgery is really something that they want to do and they're comfortable with the risks of potentially losing it due to, if their building gets bombed or something like that. But as far as support, we can support anyone with that is looking to be trained, or anyone with an internet connection. That way we can kind of interface that way. But that's where remote support comes in hand, and we've been successful at that so far.
Thank you for that. Thank you. For trauma, I'm not sure what the role is at the moment, but time will tell, of course, to see whether they will be more helpful in the future. Paul, a question for you from Nahid Khan. What are the sectors of orthopedic surgery that are using robots?
You mean what type of procedures?
Yeah, what type of procedures? Yeah.
Yeah, so largest one is total knees and unis at the moment, with hip replacement coming behind that. There is some talk about looking at it for smaller joints such as shoulders and ankles, but with that having lower procedure rates, that means lower cash involved. So it seems to be chasing the big numbers at the moment, which is total hips and total knees.
Yeah, I think that's right. It's major kind of joint replacements from what I've seen as well. You're right.
Yeah.
Cos Fantis, a colleague of mine, asking about any recent advances in neurosurgical cranial robotic surgery. Now, we know, for example, that neurosurgeons have always used quite a large kind of robotic systems to plan surgery pre-operatively using virtual reality, augmented reality now, and they are now FDA approved to be able to use an MRI or DICOM image to overlay information on the head, for example. So we've seen that now coming in, and now 2 or 3 companies have FDA approval. In terms of robotic surgery, I'll leave that question to Tim. Have you seen anything in robotic surgery for the brain and the cranium?
It's a bit far north for me. I'm normally down the other end of the pelvis. I'm not quite sure I can help you out with neurosurgery, so I don't have any particular insights on the neurosurgical front.
Yeah, I think mainly what I've seen so far is really the fact that you can plan it better using AI algorithms now, overlay information, etc. And now we are seeing robots now being developed in that field to be able to perform operations autonomously and self-directed, but also assisting the surgeon. And so that's kind of work that's been going on, of course. Let's go for a few more questions. Here we go. All right. So, here we go. It's a relevant question. I think there's a lot of conversation, Tim and Peter and Bhavan, on surgical practitioners. And of course, people are talking about physician associates, and there's been a lot of course, controversy on the internet and on Twitter on that discussion. Question is really about robotic coordinator. And what are our thoughts as a panel on permanent assistants to support the operation who are not doctors? So Bhavan and Peter, let's go to Bhavan first and then Peter.
So this is quite an interesting question, because we often get asked, should we ask our trainees to assist? And we have to always go down to the question, what is the purpose of their role? Is this because we're trying to train them, or are we using them as a service provision? And if it's part of the training process, I think they should be included. I think there is benefit in trainees spending some time on the bedside, because it helps them become a better consult surgeon. So that's the first aspect of it. The second aspect is, in the long run, for a program to be sustainable and resilient, I think it is useful to have a regular assistant on the bedside. And it may be preferable for that not to be someone who's part of the surgical team, because it'll benefit trainees as well. Because what you want them is to go through a modular training program where they spend a proportion of their training on the bedside, but then they come onto the console side. So I think it is a hybrid model. I don't think there's one or the other. There are benefits of both.
Peter.
Yeah, I'd echo that. You can maybe do 10 bedside assists, but beyond that, I think probably what you're going to learn as a trainee is limited, and you want to get onto the console. Now, if you're going to get onto the console, where does the consultant go? Ideally, they want to be on the second console showing you what to do. So then you're stuck with who's at the bedside. And that's really where surgical first assistants, robotic practitioners come in. They are a constant. They know how you work. They know all of your little nuances, and they will actually, in the long run, allow your trainee to train. So trainees can get very concerned about the competition from surgical assistants, but actually those surgical assistants will do the hard work at the bedside to allow you to train and get up your learning curve. Because without them, the consultant has to go on to the bedside, and they don't want to do that either.
Two quick questions. We'll keep the answer very short. We've got 3 minutes left. Jonathan Noel, good to hear from you. I hope you're well. Ergonomics. Is the CMR system different to intuitive, open versus closed? Who's tried both those? Who wants to answer that? Bhavan?
I think they are slightly different. I don't think they're too different, but there are nuances within both robotic systems. For someone like me who's primarily experienced with intuitive surgical, I feel more comfortable with an intuitive surgical system. But others have different
open console versus closed console. What are you thinking? Because obviously open, you can sit there with some glasses and operate the CMR. Otherwise, you're kind of punched in, right?
My view on that as an open console is probably better. One of the issues that we have with more traditional intuitive type models where you have a closed system is non-technical skills become a challenge. It is incredibly difficult for you to communicate clearly to your bedside assistant and your theater staff. So I think open models have definitely an advantage.
And they may be the future as they get better and better with 3D visualizations. Last question from Moby, Moby Rahman is a consultant cardiac surgeon at the Royal Brompton Hospital. He's asking a question about, there is a concern that robotics is not supported in specialties where it's less popular, but still has great potential, such as cardiac surgery. How can that be addressed in specialties that are not as popular for robotics? Tim? Oh no, Peter, take it.
Yes, I think that's for the specialty organisations and the colleges and your associations to to promote and for you as an individual, if you think robotics is the way forward, then gather some of your colleagues and write a business case and start developing some evidence base to support that.
Thank you. Now, we've got a minute left. I want to thank the audience for attending our first webinar. The next webinar will be in a month's time. It will be looking at sustainability in surgery, looking at how we achieve net zero, a new concept that we've been discussing for a while in our website. Please do register at Surgery.International for more latest news and also more news about the webinar, and do bring some interest in that area. I'll thank the panel for the wonderful discussion. I've had a great hour. Hope you enjoyed it too. And we'll see you in a month's time. Thank you very much.